Welcome back to the deep dive. Today, we are really getting into the nuts and bolts, the essential foundations of procedural excellence in endoscopy.
That's right. We're aiming to move beyond just a checklist and really understand the system of safety. This is specifically for you, the endoscopy technicians and nurses working in the field.
And we should mention, a lot of our synthesis today draws from fantastic expert workflow resources, including the really clear educational materials put together by Dr. Raju. His videos are excellent primers.
Absolutely. Great stuff there.
So our mission today, to really boil down that foundational setup process. What are the core risks? What habits must be ingrained? Because as you know, working in the GI lab, there's just no margin for error.
None at all.
We're framing this whole discussion around a central idea. The endoscopy setup is basically 2 stages, 1 performance.
I like that.
Yeah, the technician's job is fundamentally to build this seamless, integrated safety system. Do that right, and the physician can just keep their focus entirely on the screen, on the procedure itself.
That two stages concept is really the key to organizing the room and your thinking. You've got these two distinct functional areas, and, well, you need to master both, no question.
Okay, so structurally, how do we define those 2 stages? What are they?
Okay. Stage 1 is what we call the back table. Think of this as your hands-on hub. It's where all the immediate supplies live, the accessories, lubricant, gauze, cleaning tools.
The consumables, mostly.
Right, the consumables. But it's more than just a shelf. It's like the tech's cognitive offload system. Every single item placed correctly there is one less thing to juggle mentally when things get busy.
Makes sense. Reduces the cognitive load.
Yeah.
And stage 2,
Yeah.
that must be the tech powerhouse.
Exactly. Stage 2 is the endoscopy tower. This is the scope's, well, it's high-tech life support system. It's that stack of equipment, it delivers the light,
The light source.
the air or the CO, the water for flushing, the suction, and critically, the image processing. That box turns the camera signal into the picture on the screen.
Right. And the physical connection is obvious. The scope's umbilical plugs right into the tower, gets the fluids, the data signals.
Yep.
But for the tech setting up, what specific actions on the tower are needed before that case even starts, beyond just plugging it in?
Oh, absolutely. Your first job is getting that tower energized. Power it on, but then you have to actively dial in the lamp brightness for the specific case, and you need to confirm the air pump level.
Okay.
And this needs to happen before the patient is even in the room.
Hold on. I have to ask, even now, in 2024, why isn't setting something like brightness more automated? Why is that still a manual check? Seems like a potential point of failure.
It's a great point, and it really underscores the need for, well, human oversight. Newer systems do have automation, sure, but they often default based on maybe the last case or some generic setting.
Oh, okay.
The tech needs to visually confirm it. Is the brightness right for this procedure? Is the light guide okay? Maybe the last case dimmed it way down. Or maybe it's an HD system with specific modes.
So the manual check ensures optimal viewing from the get-go.
Exactly. You need that system energized and calibrated correctly. Can't skip it.
Okay, understood. Let's pivot back then to stage 1, the back table. We all know what gauze is, right? But for someone experienced, maybe a nurse training a new tech, what are the, say, 3 or 4 items there that carry the highest risk if they're missed or misused?
Excellent question. Let's skip the basics and focus right on risk, I'd say. The bite block, the 60cc syringe, the auxiliary water connector if you're using one, and honestly, the label pad or labels themselves.
Okay, let's break those down. The bite block, the source calls it the mouth guardian. Sounds important.
It is. And it's not just about protecting the patient's teeth, although that's important too. It's absolutely non-negotiable because it protects the scope.
Right. Damage to the scope itself.
An accidental bite on that insertion tube, or worse, the lens, that's a repair bill in the thousands. Plus, it compromises sterility, potentially delays the next case. It's a critical safety buffer. Simple, but critical.
Okay. What about that 60cc syringe? Seems basic, but you flagged it as high risk. Why?
Because it's the water engine for irrigation during the procedure. And if you don't manage it correctly from the start, you introduce risk.
How so?
You absolutely must draw water from the basin into that syringe immediately after setting up. We call it priming the flush. It's proactive.
Priming the flush, okay.
If you wait, and then mid-procedure the physician needs a flush, and you grab an empty syringe, connect it, and push, you inject air, not water.
Which could cause problems.
Big problems. Insufflation errors, or potentially, in certain situations like the upper GI tract, even a risk of air embolism. Priming that syringe is pure safety. It has to be ready with water.
Got it. And speaking of water and flushing, let's talk infection control. The auxiliary water connector, you flagged that one too.
Yes, this is huge point for infection prevention. This connector, it's an extra line, often used for jet washing, giving you more flushing power.
Okay.
The absolute unbreakable rule here is single use stays single use.
Like the analogy in the source, everyone gets a new straw for their drink.
Exactly like that. This little plastic connector, it gets thrown away after every single patient. Doesn't matter if it looks clean, doesn't matter if it was barely used, discard it.
Because reusing it creates a direct path for cross-infection.
A direct path. It compromises the entire procedure's safety, potentially making the next patient sick. Non-negotiable.
Okay, so we know the key tools, the high-risk items. Now, the crucial part is the order, the workflow. The source talks about mise en place, like in a kitchen, preparing everything first so the performance is calm.
Precisely. That setup workflow is all about organization and, very importantly, traceability. So, step 1. Open and organize.
Laying the foundation.
Yep. Spread out your transport pad, fold the edges up, simple trick, but it creates a barrier, stops things rolling off, and then critically label that pad, time, date, your initials.
Why the initials and time date?
Accountability. It
Yeah.
proves who built this safety system and when. If there's ever a question later, you know exactly when this setup was prepared. It's built-in traceability.
Okay, pad down, labeled. Then we arrange the gear.
Step 2, lay out and label. Now you place your essentials, gauze, lube, the syringe, the buttons for the scope, the basin. And you fill the basin typically with about 500 milliliters of sterile water.
And you mentioned labeling again.
Crucial. You must label both the basin itself and the syringe you fill from it. Again, time, date, initials, and sterile water. Labels answer that vital question. What fluid is this and when was it prepared? If you can't answer that instantly, it's a risk.
And this labeling becomes even more critical if simethicone is added, right?
Exponentially more critical, yes. Step 3. If ordered, add simethicone. This is a place where labs can sometimes slip up.
What does simethicone do again?
It helps break down bubbles. Gas bubbles that naturally form in the GI tract can really obscure the view through the scope, so it improves visualization.
Okay.
But if you add it, that basin and that syringe absolutely must be labeled clearly. H-euro plus simethicone. Time, date, initials too. No ambiguity allowed.
And this is where the instructions for use, the IFU, become really important.
Bingo. You hit a critical point. The tech must mix and use that simethicone strictly according to the manufacturer's instructions for use, IFU.
Why so strict? It's just bubble medicine, right?
It seems simple, but IFUs are regulatory and safety documents. Here's why. If you mix it improperly, maybe too concentrated or use the wrong type, simethicone can leave the sticky residue behind.
Right.
And that residue can be incredibly difficult to clean off the scope channels later. More importantly, it can interfere with the high-level disinfection process.
So a shortcut here messes up the reprocessing later.
Exactly. You risk compromising the sterility for the next patient because you didn't follow the IFU precisely during setup. It's a downstream safety failure from an upstream shortcut.
That really shifts the perspective. Okay, so water's in the basin. Maybe with simethicone, everything's labeled. What's next?
Step 4, prime the flush. We keep coming back to this. As soon as that basin is ready, draw water into your 60 cc syringe immediately. Don't wait. It needs to be primed, ready to act as that water engine the moment the scope goes in. Avoids that air risk we discussed.
Got it. And the final setup step.
Step 5, assemble the scope head. This is where you actually put the controls onto the instrument itself. Attach the blue air water button, the red suction button, put the biopsy cap on to seal the port. And if you need it for the case, attach that single-use auxiliary water connector now. Only at this point is the scope fully assembled and ready for its crucial test run.
Which brings us right to the pre-flight check. I like that term from the source. It emphasizes no patient contact until this scope proves it can fly.
Absolutely. It's the wet basin function test. 3 mandatory checks.
And we need to go beyond just naming them. Let's talk about what failure looks like, what it means.
Good call. These 3 tests confirm the critical pathways are clear and working. Suction, air delivery, and lens washing. And key point. The tip of the scope must be underwater in that basin for all 3 tests.
Okay. Test 1. Suction. What's good, what's bad?
The suction test. Press the red button. Success. You should hear and feel a strong vacuum pulling water powerfully into the scope. When you let go, you might get a little puff of air back. That's good, clear channel.
And failure.
Failure is weak suction, maybe a clicking sound, but no real vacuum. That signals a clog somewhere. Or maybe a bad seal in the system. Needs fixing now. If you can't suck fluid out, you effectively can't see during the procedure.
Right. Test 2, air, checking the insufflation.
The air test. This time, a light press on the blue button. Tip still underwater. Success is obvious. A steady, robust stream of bubbles coming from the tip.
And if you don't see good bubbles,
If you get just a tiny trickle, or worse, no bubbles at all, that's a major problem. Could be an air leak, could be the pump itself isn't working right, maybe a line is disconnected somewhere back at the tower.
and the consequence.
No effective insufflation. You can't gently inflate the colon or stomach to get a clear view. The scope becomes basically useless for diagnosis.
Okay, final check. Lens wash, keeping the view clear.
The lens wash test. Now it's a firm press on that same blue button. Success here is visual. You need to actually see a strong, direct jet of water spray out from the nozzle right across the lens area.
And what does failure look like here?
A weak dribble, maybe the spray goes off sideways or up instead of forward. That means the nozzle's blocked, often with tiny bits of debris. If you can't wash blood or mucus off the lens mid-procedure,
The view goes blind, and the procedure stalls.
exactly. Test fails, procedure cannot safely start. Fix it first.
Okay, so the system's built, checks passed, ready to go. Let's connect this to the actual case. That analogy about the windshield washer and wipers, it really clicked for me. Explain that synergy.
Yeah, it's a great way to think about the coordination needed. Imagine the physician is driving the scope, and suddenly the view clouds up, fluid, bubbles, whatever. It's like driving in the rain.
Right, you can't see.
Instantly, the physician needs clear vision. So the tech, who should be watching the screen too, sees the cloudy view and immediately uses that primed 60cc syringe to push rinse water into the scope's irrigation port.
Feeding the washer fluid.
Precisely. And at the exact same moment, the physician uses the controls, taps the blue button, framely,
Splay.
to spray that water across the lens, and then quickly taps the red button,
Suction. Wipe.
exactly, to suck the dirty fluid away. Spray and vacuum. It has to be lightning fast coordination. Technician feeds water, operator washes and wipes.
And if the tech hadn't primed that syringe earlier,
Then you get that fumble, that delay. Or worse, they push air by mistake. It completely disrupts the flow, potentially at a critical moment. Preparation enables that seamless teamwork.
that reliance on smooth coordination brings us back, one last time maybe, to those absolute safety habits, especially infection prevention.
We really have to hammer this home. That single-use stays, single-use rule for the auxiliary water connector is sacrosanct, non-negotiable.
After every single patient, it goes in the bin.
Every single one. Doesn't matter how busy it is, time pressure cannot be an excuse to break this fundamental infection control barrier.
And the final, critical safety habit, the instant the scope comes out of the patient.
The immediate visual cue. As soon as that scope is withdrawn, the technician must immediately place that biohazard dirty scope label onto the instrument.
Not just set it aside to label later.
No, right away. This isn't just paperwork, it's a crucial safety signal. It tells everyone, visually, instantly, this scope is contaminated and must go directly to reprocessing.
It prevents any chance, even momentary confusion, of it getting mixed up with clean gear or accidentally reused.
Exactly, eliminates that risk entirely. Simple habit, huge impact.
Okay, this has been a really focused deep dive. Let's try to summarize the absolute core takeaways for everyone listening.
I think the main thing is seeing the back table and the tower not as separate stations, but as one integrated safety system. Every single item, from the bite block protecting the scope to that tiny single-use connector preventing infection, has a specific risk mitigation role.
And getting it operationally ready isn't just grabbing supplies. It requires those precise, documented steps we talked about.
Right. The 500 milliliter of water, the disciplined labeling of everything, following that IFU to the letter if simethicone is used.
And crucially, passing that three-step pre-flight check. Suction, air, lens wash. Actively looking for those failure modes, not just going through the motions.
That whole disciplined approach, honestly, it builds skills way beyond just endoscopy setup. It applies to any complex, high-stakes job.
It really does.
Yeah.
You know, great endoscopy often looks effortless, doesn't it?
Right.
But that effortlessness comes directly from disciplined, proactive setup.
That's the truth.
So here's something maybe to reflect on, building on what we've discussed with the source material. Once you truly grasp the why the labels matter, why that connector is single use, why those 3 tests are mandatory, you kind of transcend just following a checklist.
Interesting. You move beyond rote obedience.
Yeah. You start actively, consciously building a safety net. You're anticipating specific ways things could go wrong, and you're deliberately putting measures in place to stop them. That understanding, that intentionality, that's the real difference between just doing the job
Yeah.
and truly owning your craft as a skilled technician or nurse.